Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about another primary bone tumor, which is also benign, and that is the osteoblastoma. Remember, in a previous video, we talked about the osteoid osteoma. Key point that we need to be able to differentiate these two bone tumors from one another. So when we talk about the osteoblastoma, let's jump in with the epidemiology. And we said that this is a benign bone tumor, and it's typically going to affect males more than females in a younger age range, approximately the 10 to 20-year-old age range. So again, this is important to keep in mind. Classically, a presentation is not going to be a 7-year-old patient who has this for the first time. It's most often going to be a teenager or a young adult. But again, this is not always the case. When we think about the presentation here, this can present with localized pain plus or minus swelling. This is really important because some of the other bone tumors we've talked about, right? The osteochondroma, the enchondroma, the osteoid osteoma, and the osteoma in previous videos, we talked about these kind of being asymptomatic or painless bone tumors. They might cause some symptoms, but not usually. They're more likely just to be felt as a mass in the body. But here we have a tumor, right? An osteoblastoma, which is actually going to have some pain present. And again, I think about kind of a memory aid here to think about the blast, right? I'll talk about a couple different things here, but the blast, if you think about a blast occurring, it's going to be painful. So the osteoblastoma is when I think about classically being a painful bone tumor. Now, another key point for this presentation is that this may cause neurological symptoms, and this will make sense to us in a minute when we talk about our diagnostics here. But the idea is that these tumors are most likely to be seen in the vertebra. And we know that the vertebra is surrounding a very important structure inside, which is our spinal cord. And if we have a tumor that is surrounding our spinal cord, the compression on the nerves can actually lead to neurological symptoms in a patient. Now, when we think about the diagnostics here, it's important to note that on X-ray, this is typically going to be a cortical bone tumor. Again, we talk about the cortex of the bone is kind of the outer portions of it, and then the inside is the medulla, the spongy bone, right? And so if you draw your attention over here to this X-ray imaging, we can see a very classic osteoblastoma present. We have a vertebra present and an outgrowth. On this side, we have normal appearing bony contours, but over here, we can see a very large expansile lesion. Again, this is a growth that is at the spinal cord. This is specifically at the cervical spinal cord. And so as you can imagine, this compresses, right? It gets bigger and bigger. It's compressing towards the central canal, which is housing our spinal cord. And that's why these patients could have the neurological findings. Now, we mentioned that this tumor is most commonly in the vertebra, but it can also be seen in the long bones as well. And here we have, again, another key differentiating feature from some other tumors that we talked about, and that the osteoblastoma is typically larger than the osteoid osteoma. It's typically greater than 2 centimeters. In the previous video, we talked about the osteoid osteoma being a bit smaller, typically less than 2 centimeters. And so again, if you think about a blast for a memory aid, right, it's painful and it's also large or greater than 2 centimeters. And so this is how I really can remember key portions of this bone tumor by thinking about the blast in the word. Now, when we think about the management here, a super key high yield point to know is that this does not respond to NSAIDs. Again, why is this important? Because we compare this to an osteoid osteoma, which does respond to NSAIDs. So again, thinking back to the memory aid, the word blast, I think it's painful, it's large, and it does not respond to NSAIDs. Again, you think about a blast, right? I think about a blast being a very big deal, a very big injury. And when I think about that as something that doesn't respond to this over-the-counter anti-inflammatories. And so those are the 3 key points here. The blast, I think of painful, large, and not responsive to NSAIDs. Now, as we said with previous bone tumors as well, the same rules apply. Surgical removal may be necessary if indicated for these patients, but this is a benign bone tumor in general, so that's not always necessary. What would be an indication for surgery? We'll think about it like this. If the patient is having a very large bone tumor that's causing neurological compression on the spinal cord, this can be an indication for surgical intervention. But if it's small, it's noticed on imaging but not causing any symptoms, you don't have to do anything about it. If it is causing symptoms, we have to think about the treatment options. NSAIDs would not be a good option because these tumors do not typically respond well to anti-inflammatories. So a potential question they could give you includes something along the lines of a 15-year-old patient presents to the pediatrician with new onset upper back and neck pain. The patient feels well overall and denies any known trauma to the area. He reports occasional numbness and tingling down the right arm as well. And the patient's mother reports they have been trying conservative measures such as stretching, ice, and anti-inflammatories, but these do not seem to improve the symptoms. The question could then ask, which of the following bone tumors is the patient most likely to have? Well, using our clues from this question stem, right? It does not improve with anti-inflammatories. It's causing right arm numbness and tingling, right? It's upper back, cervical, neck pain, likely to have involvement of the vertebra. Well, the most likely bone tumor that this patient has is the osteoblastoma. Again, there's tons of clues in there. Another key one is the age of the patient. If they talk about a 15-year-old patient, that really fits nicely into our typical or classic age range. So just a quick summary to wrap up this video. This is osteoblastoma. Again, we want to be able to compare and contrast these primary bone tumors. We want to specifically compare and contrast this to osteoid osteoma, which we talked about in a previous video. The epidemiology here is typically going to be seen in a younger patient, although not always. Presentation, we often have localized pain with swelling and potentially neurological complications. Why is this? Well, if we think about our diagnostics here, this is typically a cortical bone tumor that's most common in the vertebra. If we have the tumor in the vertebra compressing on the spinal cord in the canal, that is how we get these neurological symptoms. So again, it kind of fits here, right? The presentation of the patient fits with the location of the tumor. When we think about management options here, key point is to differentiate that osteoblastoma does not respond to anti-inflammatories versus an osteoid osteoma, which does respond to anti-inflammatories. A memory aid I like to use is to remember the word blast and blastoma. It's painful, which we talked about here. It's large, a blast. I think about being large. We talked about that here. And it does not respond to NSAIDs. I think about it being a big, painful blast that is not easily treated with anti-inflammatories. So that's how I kind of keep this tumor straight in my mind. Now, although NSAIDs are not useful for this particular condition, patients may be indicated for surgery, particularly if they're having these neurological compressions, if they're having nerve compression because the tumor is pushing on the spinal cord. That could be a possible indication for surgical intervention.